Hello, my name is Marina Konoppleva. I'm a professor in the Department of Leukemia at MD Anderson Cancer Center. I will present for you today the lecture on Diagnosing BPDCN, Immunohistochemistry and flow cytometry. BPDCN originates from the Plasmacytoid dendritic cell, which are normal components of peripheral blood cells. The PDCs are the intermediates between innate and adaptive immunity. They can recognize the antigen through the toll-like receptor, and they can secrete cytokines such as interferon alpha, IL-6, IL-8, and TNF-alpha. And this subsequently results in the activation of T cells along with NK cells and macrophages. PDCs express a variety of the markers, which is also preserved in the BPDCN. You can see on this slide that they express the cell surface of CD123 or IL-3 alpha chain, CD56, CD4, and some additional markers. In addition, they express the marker TCL1 on the nuclear membrane and TCF4, which is a transcription factor expressed intranuclearly. BPDCN, or Blastic Plasmacytoid dendritic cell neoplasm, is a malignancy which is highly aggressive and has multitude of presentations. These include cutaneous, lymph node involvement, bone marrow, and occasional CNS involvement. The histology of BPDCN is represented as blastoid or pleomorphic appearing tumor cells. In addition to the CD4 and CD56, they express a variety of markers such as CD123, TCL1, BDCA2, CD2AP, and others. Of importance, the BPDCN cells are negative for the myeloperoxidase and additional markers shown on this slide. This slide summarizes again the positive markers which are required for the diagnostic of BPDCN and the exclusion markers. Amongst positive markers, you can again appreciate CD4, CD56, and additional CD123, TCL1, and TCF4. The exclusion markers have to be negative for any lineage-specific cytochemistry or flow cytometry. This includes myeloperoxidase, CD123, which are AML-specific markers, CD64, B lymphoid markers such as CD19, CD20, or CD79A, and T cell markers such as CD3 or CD7. These all have to be negative for the diagnosis of BPDCN. The morphology of bone marrow BPDCN is represented by the blast-appearing cells shown here. They have a large nucleus and scant cytoplasm and can frequently appear as sheets. In the immunohistochemistry of BPDCN, the cells again are positive as shown here by the example for TCL1, CD123, and CD56, the classical markers for BPDCN. The flow cytometry supports the diagnosis by showing co-expression of CD123 and CD4 and high expression of CD56 with negative CD64 marker. This can be easily remembered as 1, 2, 3, 4, CD123, CD4, and CD56. This slide reproduces again the immunophenotype of bone marrow BPDCN by flow cytometry. This analysis has looked at a number of primary BPDCN samples. The majority of them have expressed the markers that I already mentioned. In addition, HLA-DR was expressed in the majority of BPDCN. They express variable numbers of TDT, CD7, CD2, CD5, and CD117, which are non-specific markers for BPDCN. However, they were negative for CD3, CD19, MPO, most importantly CD64, also CD34, CD8, and CD13. If you have positivity for MPO, this is most likely AML and not BPDCN. If CD3 is positive, this is more likely TLL and not BPDCN. And CD19 highlights B-ALL and not BPDCN. The cytogenetics for the BPDCN was studied in several publications. In this particular study, majority of the patients had diploid cytogenetics, but a fraction had complex cytogenetics, and few of those had deletion 12p13 or deletion 20q. Amongst molecular markers, very commonly we see mutations in the gene TET2, which can also include variants and mutations. Other mutations that are common for BPDCN are ASXL1 and RAS gene. In addition to the classical BPDCN, the pathologist can frequently encounter reactive PDC proliferations in various types of diseases. This is not BPDCN, and you can read the different phenotypes which can have the PDC proliferation, including lymphomas, inflammatory conditions, and some cutaneous conditions. However, recently it was recognized that tumor-forming PDC can happen in subset of myeloid malignancies, and this could be clonally related. For example, these are found in chronic myelomonocytic leukemia and other myeloid neoplasms with monocytic differentiation. This can be seen in skin, lymph nodes, spleen, or bone marrow, and some of the studies have shown that these PDCs are clonally related and they carry RAS mutations. It was also shown that patients who have the PDCs in the bone marrow sections, they have a higher chance of transformation into acute myeloid leukemia. This provides the rationale for targeting these PDCs not only in BPDCN, but in some additional myeloid neoplasms such as CMML or myelofibrosis. In summary, BPDCN morphology is of blastoid or pleomorphic appearing tumor cells. BPDCN tumor cells have characteristic markers of CD4, CD56, and CD123 positivity and TCL1. They have to be negative for MPO and other lineage markers. Recent findings indicate that tumor-forming clonally PDC proliferations can be found in other diseases outside of BPDCN, such as other myeloid neoplasms. Thank you for listening for my presentation today.